PhDs, and then they publish, and that explains to some extent the numbers. But I must say it's quite fun to do that, because it's very rewarding if you see that you can take people to the next level and they go back to their places, and now we build with these people that are all over the map, if you want, sort of consortia. And they can still keep doing research, although in their places this is non-academic, so they have to work hard, but they can still contribute to things. And for them, that is something really, triggers them to not purely work clinically, but also keep on doing research. Let me see. Can I get this first slide? Right, it's quite a complete story about that. So I was supposed to talk about this rather complex topic. I enjoyed the talk by Joel, and that's the things that we have been doing, and we make steps forward, but we also go in directions like he showed, the thin fibrosis in the ventricle, you cannot see it, you have to rely on numbers. If we go in the direction of AI, we have to go even more in the direction of numbers, and we don't see pictures. I like to see pictures because I have an idea what I'm doing. So I took a couple of statements from other articles. So what is it all about this? This is about vascular inflammation. So it's really a step further than we have always been doing. And it's not so much a step further, but it's a step earlier in the disease. So what is happening in the coronary arteries and in large vessels as well? This vascular inflammation plays a very important role in the development and progression of coronary atherosclerosis. So if you want, it's an early precursor of the atherosclerotic disease. The earlier we come in whatever medical pathophysiology, the higher the likelihood is that we can do something good for the patients. The way we work, I look at Joel's beautiful work, but you speak about patients that are end stage, they have tricuspid regurgitation, secondary to RV dysfunction, secondary to LV dysfunction, secondary to severe MR, and then we come and we put a clip. And the patients improve in symptoms, but we're not doing anything on longevity. So I think if we want to make a step forward in medicine, we have to go earlier. One good example is the PROGRESS study from Edwards, where we put now a transcatheter valve in half of the patient group at moderate aortic stenosis before they become severe. Because as Joel showed, a lot of the stuff that happens in the coronaries or the valves starts as a ventricular problem. There's all this fibrosis, so we come earlier, we actually have a chance to do something. So detection and quantification of vascular inflammation is what it's all about, and this may assist in early risk stratification of coronary disease, probably, hopefully, before development of coronary plaque. You know what Novartis, for example, is doing. They push all these medications that work on inflammation, the smart drugs, if you like. In the last years, we've seen a lot of development in that, and the hope is that if we can give them the targets, they can do the treatments. So inflammatory cytokines change the characterization of this pericoronary adipose tissue, because in the normal individual it's also there. It inhibits lipid accumulation and adipocytes differentiation, and CT can detect these changes as an increase in CT attenuation, Hounsfield units, and the more minus 190, I always get confused also with the string, minus and positives, etc. You never, but minus 190 is good, and if you go in the direction of 60 minus, that's bad. Then you start to get inflamed tissue. This is what it looks like. I think this is a very nice graph. Healthy conditions on the left. Yeah, on the left. So the red is the vessel. You see the PVAT, pericoronary fat. And these are nice big cells. And so what happens under healthy conditions is that the perivascular adipose tissue exhibits anti-contractile and anti-inflammatory properties in response to the enemies that are coming, the markers of oxidative stress and inflammation. So under inflamed conditions, when we go to the right, these big cells become small cells. Under inflamed conditions, the PVAD undergoes unique phenotypic changes due to vascular inflammation. And the hope is, if that we come with these smart drugs, that we can interfere in this process. But then we need something to show it to us. So that's where the imaging comes. So under inflamed conditions, this PVAD undergoes unique phenotypic changes due to the vascular inflammation compared to non-perivascular adipose tissue located from the vessel wall. Here you see visualized what that looks like, because it doesn't look like that if we see it, but the imaging companies make it possible that we start seeing it. On the left is panel A, that's what a normal situation would look like. On the right is panel B, that is what an inflamed situation would look like. So the Hound-filled units are going to go from -200 or something in the direction of -60, 40, and so on. And that is where there is significant inflammation. And this is the picture that you see. I think this is a difficult one to work with, right? Because we're very used to looking at the focal, local stenosis. Now we have to think differently. So this is not a target for whatever intervention or so. We're not going to do PCIs on these patients. But if it would work with the novel medications that I just indicated to you, then we can select the patient based on this sort of softwares and send them for the medical treatment, early treatment, because these drugs are not cheap, as you know. So this was the CRISP study. I think beautiful thing. When I read it for the first time, I had to read it 5 times before I understood what it was really all about. It's a post-hoc analysis in 2 prospective independent cohorts, one coming from Germany, one from the United States. The one from Germany is from Stefan Affenbach's group, and it's just consecutive patients undergoing coronary CT. So the primary objective of that was to look at the predictive value of perivascular fat attenuation, PVAD index, for 2 primary endpoints being all-cause mortality and cardiac mortality. And when they incorporated this PCAT in sort of an algorithm, they were able to make a difference. These were the pictures that I just showed you, so you can measure that like that. You can measure it in the different vessels. What you see here is that you got different softwares. This software works with taking little pieces. Eventually, I think little pieces, as you see on the CT scan, is working where there is already stenosis. That's not what we want. We want to go earlier. So we want to go earlier. We're not going to look for stenosis on the CT scans and then do this analysis. We're going to take vessels where we do not see much. And this study actually shows that these fat attenuation indexes of lesions that were already visible there on the RCA and the LAD were associated with all-cause mortality and cardiac mortality. And then there was a problem because the circumflex somehow didn't work. When we work now with the Medis software, we don't find that problem. We see that we can do in all different vessels. So this is of course the most important. These fat attenuation indices, they were related with outcomes, bad outcomes. So that's where we want to go. And if they then do the maths, then they see that the receiver operating curve, that it's better when you do that FBI than when you do the routine stuff. So the conclusion is the perivascular fat attenuation index, when measured around the right coronary artery, specifically the right, predicts all-cause mortality and cardiac mortality over and above the current risk stratification as we do it. So the integration of this may give us a new tool to treat patients earlier. So this is what we have been doing so far and working with Medis. I know Hans Reiber very well. He lives opposite of the university and I see him on a regular basis. So when I learned about this, I said I would like to go into this and I would not like to do just one spot. I want to do the whole vessels. So higher peak attenuation in the direction going less minus, so from minus 160, 190 being normal to minus 30 or so, is associated with plaque characteristics, non-calcified, mixed. So we started with that. We started with the routine stuff, where I see something on the CT, and I know, because we published so many years for the first time, that the non-calcified plaque in 2007 in JACC, we were doing a care track, because we didn't have a fast track chest pain unit. So what we did when the patient came in during the day and they didn't have an infarction, they just had an ECG that they didn't feel comfortable, they had complaints, and we did the CT scan with them. And if the CT scan was positive, we took them straight in the cath lab, only during day hours because we could not do that at night. And we didn't have like what you have now, this where you can do an exercise test, etc. So we did it with the CT. And with that one, when we put these patients in, I saw for the first time that really these non-calcified plaques in those patients that were positive were extreme. There was almost hardly any calcium when they came very young. So I think that you go earlier in the disease. So that is the state where we're looking at here. So PCAT in patients with ACS versus stable CAD. ACS, unstable disease, more inflammation. PCAT closer to, let's say, this -30, -50. And stable disease, lower PCAT, more in the direction of 190. So we looked through our database, what we have, 2005, 2015, and we selected out the patients that after the CT scan developed within 2 years, maybe you say that's a pretty long time frame, maybe yes, maybe no, developed a non-STEMI or a STEMI or an ACS and were hospitalized for that, and we have the information on that. And we compared that with patients with stable CAD for the moment, so I'm not going down yet to the level where there's nothing that I can see and work with that, with medications or so. So we did a propensity score matched 1 to 2 for age, gender, cardiac risk factors as indicated there. Excluded were the patients with previous revascularization because then the whole interpretation becomes difficult. And this is what it looked like. So here you see the STEMI ACS in red, you see the non-STEMI ACS, and you see the unstable angines. And all of that goes in the direction what we just spoke about, not to -30, but to -60. -30 is extreme, and it depends also on the vendors that you have, it depends on a lot of things, but you see that the STEMI ACS go lower, so more damage than the non-STEMI ACS, and the unstable angines have the least. I don't have a conclusion. I cannot say where this is going to go, but I have the hope that if we team up with pharma industry and we can start working on these things and better define these patients, that we can come with earlier treatment in the hope that we at least partially prevent what we are still treating nowadays. Acute infarction, ischemic lesion, etc. Thank you very much.